Hi and welcome to this educational video brought to you by the Society of Mechanical Ventilation. Proportional Assist Ventilation. PAV.
Hi, today we'll be talking about proportional assist ventilation or PAV. So let's start by describing what is PAV. Basically, it's a mode with a servo targeting scheme where the output of the ventilator, meaning the pressure, the volume, the flow, automatically follows a varying input. And in that case, the input is the patient effort. We'll describe it more in details, but basically it's a continuous, spontaneous mode with a variable pressure support. And we'll try to discuss the difference between this mode and pressure support. The pressure support or the driving pressure delivered by the ventilator will vary, and it will depend mainly on the patient effort, the percent support dialed by the clinician, and the respiratory mechanics. So proportional modes of ventilation, not only including PAV, there's a couple of other modes like NAVA or proportional pressure support. Basically, those modes, they assist the patient by adapting to the patient effort, which is different with all other modes, basically by amplifying the effort of the patient respiratory muscle activity. So the patient breathe more, the ventilator give him more work to keep him in the comfort zone. At the same time, providing the necessary support basically to improve the balance between the capacity and the demand and to reach the patient ventilation goal at the same time. This is one of my favorite graphs here that describes some of the relationship of the patient work and the ventilator work in different modes. So if you look at the orange line here, this is the patient work from 0, meaning the patient has no effort at all, paralyzed, to 100%, meaning he's doing all the work. And this is the ventilator work again from 0 to 100. And if you look at the orange line, that's a volume control mode and the pressure regulated volume control. And if the patient effort is 0, the ventilator is doing all the work. The more the patient start doing more work and creating more tidal volume by himself, what happens is the ventilator would start decreasing the delivered amount of pressure to keep the tidal volume in the range dialed. So basically, the more the patient do, the ventilator do less, which is very non-optimal and cause a lot of dysynchronous. In pressure-controlled modes like pressure-controlled ventilation or pressure support ventilation, the delivered pressure is the same regardless of the work of the patient. So the ventilator gives the same amount of pressure each breath regardless of the work. So if the patient is paralyzed, we'll give him the same amount of pressure. If the patient starts to work, increasing the work, again, it will be the same amount delivered by the ventilator, but of course the tidal volume will go up. So a little bit better than the volume controlled modes and the pressure regulated volume control, but again, not very optimal. The optimal is to have a mode that adapts to the patient's effort. So the patient start having more effort, the ventilator gives them more pressure or more work. So it's the work of the ventilator is proportional to the work of the patient. And that helps a lot, mostly in synchrony and to avoid muscle fatigue. So how does proportional assist ventilation work? Basically, the software of the ventilator delivers the assist again in proportion to the flow and the volume generated by the patient inspiratory effort or the muscle pressure, we call the PMUS, which is estimated from semi-continuous automatic measurement of the respiratory mechanics, applying the equation of motion of the respiratory system. So basically the ventilator does a lot of calculations to try to estimate the respiratory mechanics, basically the resistance, elastance, by doing a short end inspiratory occlusion about 250 to 300 milliseconds every 8 to 15 breaths, and displays the compliance, resistance, and auto PEEP. The idea of how does the ventilator knows the muscle pressure or how much pressure to apply to the patient comes from the calculation of the equation of motion, which says that the total pressure applied, of course, is shared between the ventilator, airway pressure, and the muscle pressure of the patient. And that's the equation of motion equal flow times resistance plus volume times elastance and total PEEP. The ventilator calculates the airway pressure based on the percent assist, that is the clinician dialed, times the total pressure required. And the airway pressure will be the PMOS, which is from the patient-generated pressure, multiplied by the percent assist over 100 minus the percent assist. You can read, there's a lot of papers exactly describing how the ventilator gets and calculates all this respiratory mechanics. Of course, the PMOS itself, or the work of breathing, the gold standard of calculating those needs an esophageal balloon. But those numbers are like obtained non-invasively, and sometimes, to be honest, are not very accurate. So you have to pay attention not only to the graphs and the numbers displayed by the ventilator. So to simplify what we just talked about, and I know there's a lot of calculation and mathematics, what proportional assist ventilation does is the ventilator estimates the total work of breathing in joules per liter and divides that work between the ventilator and the patient according to the amount of pressure support dial. So if you look at that bar that usually displayed by the ventilator, and here it goes between 0 to 2 joules per liter, and it shows you that the total work here was about 1.5. The dial support was 75, so the patient's work is doing 25% of the work, the ventilator is doing 75% of the work, and it shows you like about 0.4 joules per liter that the patient is doing. It even puts like that yellow curve that's within the normal range for the total work, and that green line is like within the normal work of breathing of the patient. So of course, the more you increase or decrease that support, if you decrease the support and the total work of breathing is still the same, you'll find that the patient will start shifting to the right. And vice versa, if you increase the support, of course, the ventilator will start giving more work, so the patient should go to the left. In this other screen here, it's like the full screen, what we talked about. This is the respiratory mechanics, compliance, 53 milliliter per centimeter water, resistance 3.3 centimeter, auto PEEP or intrinsic PEEP was 0. This is the airway pressure, or the pressure. This is the graph that we just talked about from the other slide, and this is the flow. On the top here is the peak airway pressure, which will be the driving pressure over the dialed PEEP. In this case is 5, so patient is getting 11 of pressure support. The mean airway pressure, PEEP again, inspiratory ratio, respiratory rate, tidal volume, minute ventilation. So the question is, how do we set the percent support on the PAV? And of course, it depends on what's your goal. Are you trying to do full support of the patient while he's still having active disease or ARDS or pneumonia? or the patient is improving and you now trying to do weaning or using it PAV as a spontaneous breathing trial, trying to disconnect the patient from the ventilator. And there is really no agreement or data or studies on the best way of doing it. There was a study done for full support where they used charts trying to look at the pressures given by the ventilator and trying to keep the driving pressure below 15 and the tidal volume, which is for me it's a little bit cumbersome. So the way basically the way I use it is if I'm using it for full support, of course I'm gonna start the percent support a little bit higher. What I didn't say, the percent support can go from 5% to up to 95, although it might be too high. So start somewhere around 80 to 90% and keep an eye, of course, on the driving pressure because if the airway pressure, say, for example, is 30 and your PEEP is 5, that's 25 of driving pressure. That's pretty high. So you can decrease that. And of course, at the same time, you're looking at the tidal volume and you're looking at where is the patient. So if you're using 80, 90% and the work of breathing of the patient is very minimal, so you can actually reduce that a little bit. And by the time where the mechanics are improving, the compliance or resistance, you will notice that the pressure, the driving pressure will decrease, the tidal volume will increase, so you can adjust the percent support to attain your goals of like driving pressure, tidal volume, of course, respiratory rate and everything. When you use it for weaning, usually say the patient is improving. Now, for example, you're in 70% support and the work of breathing of the patient is down here. You can start decreasing it. Usually when you reach about 25% support, meaning that the patient is doing the majority of the work, 75%, and the ventilator is doing 25%, and say the peak inspiratory pressure is low, like for example, 11 while your PEEP was 5, so the ventilator is giving the patient 5 to 6 pressure support, which acceptable for weaning. And then the next slides will show how to set the mode, how to pick it, how to adjust it on the Puritan Bennett 980 because the PAV Plus software is only licensed for that ventilator. So of course, if you don't have that ventilator, you're not going to be able to use PAV. Of course, there is some similar modes like proportional pressure support on Draeger. There is the NAVA on the Mackay Servo, although it's a little bit different, but again, proportional ventilator mode. And we'll try to talk about those modes in upcoming lectures. We'll start this video by talking about how to set proportional assist ventilation. This is a Covidian Puritan Bennett 980 ventilator, and we will be using a long simulator. So we'll start by choosing, of course, the patient's weight, gender, male, female, and it calculates the ideal body weight. There's the options of invasive and non-invasive, and the modes available, assist control, SIMV, spontaneous and bi-level, and of course PAV is a mode of spontaneous ventilation. So once we push spontaneous, you have the option of pressure support, tube compensation, volume support, and PAV. So we'll pick the PAV, and you have the option of pressure trigger versus flow trigger. And those are most important settings here. The percent pressure support, and you can go as down as 5 or as up as 95%. Of course, the sensitivity, whether it's flow trigger or pressure trigger, the FiO2, the maximum amount of pressure you want to give the patient, what kind of artificial airway, whether it's an ET tube versus tracheostomy, and you have to put the size of it, the expiratory sensitivity, because it's a pressure support mode, how amount of PEEP applied, and what's the maximum tidal volume you want to give the patient. Once you're set on those settings, we will start ventilating the patient. And if you notice here, it gives you, that's a screen for proportional assist ventilation, the pressure, airway pressure, the flow trigger, the flow, this is the tidal volume, and the work of breathing. This bar is very important because PAV try to calculate the total work of breathing, as you can see here, and the work of breathing of the patient. So basically, you can monitor how much the total work and how much the patient is working. What PAV also try to do, it's try to calculate the dynamic respiratory compliance and the airway resistance and the amount of intrinsic or auto PEEP. And if you notice here, this will be proportional to the work I'm doing. So right now, if you notice, I'm not pushing too much on the lung simulator, so the patient is getting peak inspiratory pressure of 11, which means like 6 over the PEEP of 5 that I applied. I'm not doing much work, so the patient is getting low tidal volume, of course respiratory rate, I to E ratio, and then mean airway pressure, minute ventilation. Notice once I start now working the patient hard, you will notice that this bar will start shifting to the right. See, it's moving right to the right. And you will notice that the peak inspiratory pressure will start to go up. The tidal volume is going up. And why is that? Because the ventilator is trying to do 70% of the work and the patient do 30% of the work. So again, I'm gonna try to breathe harder. Again, so the ventilator increase the airway pressure, the tidal volume is going up. And you can see that the work of breathing for the patient, this bar here, and the total work of breathing, they're both start to shift to the right. So now how are we gonna start weaning the patient with the PAV? Of course, it depends on if you think the patient is clinically improving, his respiratory mechanics, including the compliance, the airway resistance is improving, and the auto PEEP. And clinically, of course, we're gonna start dialing down the percent of support. And of course, you can go slow as much as you want. You will be noticing on these settings how much pressure support this patient is getting. So right now the peak is 13, meaning he's getting 8 over the dialed PEEP. How much tidal volume, of course, how is the respiratory rate. You do all your weaning parameters for the SBT. Usually once the patient is down to about 25 or so of the support, meaning that the patient is doing 75% of the work, and the work of breathing of the patient is within that acceptable 0.3 to 0.7 joules per liter, and the total work of breathing for the ventilator is acceptable. Now the patient is probably ready. If you can notice here, the peak inspiratory pressure is about 9, so meaning the patient is getting about 4 of pressure support only. Tidal volume is good, respiratory rate is good, so probably the patient is ready to be extubated. Thank you. Some of the benefits and pitfalls of proportional assisted ventilation, mainly the benefits are better synchrony, because in that mode the patient is the one who dictates the flow, the volume, and the cycling, and the ventilator basically try to amplify his signal, so the patient has full control his respiratory pattern. So that's one of the big important benefits of proportional assisted ventilation. When the patient does this with decreased synchrony, you might have some reduced sedation, you might have some patient comfort. Again, I'm saying might because it's not 100% documented or proven. Again, if you set the percent support from the ventilator adequately, you might help the respiratory muscle unloading and neuromuscular coupling of the patient. The question of lung protective has been studied. Again, it's not proven. It's possible that it might be lung protective, but mostly diaphragmatic protective. Again, we know that disuse atrophy or diaphragmatic atrophy happens especially in heavily sedated or paralyzed patient. So having the patient in a spontaneous mode might reduce diaphragmatic dysfunction. There was some studies comparing does it offer better weaning compared to pressure support, as pressure support is only one level of pressure during every breath, which is really not the natural way we breathe. And there's some not very strong evidence that it might be helping faster weaning. Now, some of the problems with proportional assisted ventilation is the PAV or the PAV Plus nowadays only available on one ventilator, as we mentioned, the Puritan Bennett. It has to be only spontaneous mode, so the patient, if he's paralyzed or having no heavily sedated, no activity, the ventilator will turn into the backup mode. On that ventilator cannot be used non-invasively, although there are studies where that mode was used non-invasively. Cannot be used with air leaks because it will mess with the settings and the calculations. And again, as I said before, the calculations can be misleading. So you gotta be better careful with that. There was some problems called runaway phenomena, which really doesn't happen anymore with the new software, and it's basically with cycling dyssynchrony. Those are some of the references that we talked about, mainly initially how to determine the inspiratory resistance and the elastance non-invasively by Dr. Magdi Yunus, who invented that mode. This is the study that I was talking about, how to adjust the settings during full support. And some of the other studies basically talking about proportional modes like PAV and NAVA. And this is another study with comparing proportional assist ventilation versus pressure support for weaning. And this is proportional assist ventilation feasibility in the early stage of respiratory failure. There is a lot of studies and data outside, and I encourage you to read more about that mode. Thank you for watching this lecture, and I hope it was beneficial. Thank you.